All right, ready to dive into a topic that's a mainstay in general practice.
Always up for a challenge.
Sensory loss. We've got a lot of really interesting research here.
And I'm betting it's going to go way deeper than just the basics, right?
Exactly. This isn't just a refresher. We're going beyond just numb fingers and toes. Uncovering those intricate pathways, those subtle signs, and those tricky diagnoses that can really make you a sharper GP.
It is funny, isn't it?
What's that?
How sensory loss can appear so straightforward at first glance.
Yeah.
But then a patient comes in and they've got this whole constellation of symptoms, seemingly unrelated.
Oh, tell me about it.
And all of a sudden you find yourself right in the middle of a neurological puzzle.
Absolutely. And that's what we're here to break down today. But first, let's just kind of like rewind a little bit.
All right, back to basics.
Yeah. So the sensation pathway, right? We all know it, receptor to nerve, spinal cord up to the brain. But here's what I find fascinating. Touch, that like the most basic of sensations, actually travels on two completely separate pathways.
It's true. It's like our bodies have this built-in redundancy system.
Well, that's so.
Yeah, you've got your spinothalamic tract carrying things like pain, temperature, and crude touch.
Okay.
And then you have your dorsal columns.
Right.
Those are handling vibration, proprioception, and fine touch.
What?
And get this touch, information goes on both. It's like nature's way of making sure we don't easily lose that crucial sense.
It makes you realize just how important that sense of touch is. Right.
Absolutely.
Okay, terminology time.
Hit me.
As GPs, we use terms like, hypoesthesia, anesthesia, hypalgesia, analgesia.
All the time.
All the time, yeah. But I'm curious, have you ever really stopped to think about how those subtle distinctions between those terms can actually help you fine-tune your diagnosis?
Absolutely. I mean, take hypoesthesia, for example. It comes up in so many different conditions.
Yeah.
But you really have to ask yourself, is it just like a general reduction in sensation? Or is it specific to certain, modalities?
Right.
That can make a world of difference. I mean, if a patient comes in and they have, let's say, diminished pain and temperature sensation, that might point you towards something like a small fiber neuropathy.
Okay.
Whereas someone with impaired vibration and proprioception, that might suggest a large fiber issue instead.
So even just noting the specific type of sensory loss can actually give you clues about the underlying nerves involved.
Exactly.
Okay, so let's shift gears a little bit and talk about the sensory exam.
Mm-hmm.
I mean, we do it constantly.
Day in and day out.
But how often do we actually pause and think about the logic behind what we're doing?
That's a good point.
Like, why are we doing this?
Well, I think of the sensory exam as this neurological treasure hunt.
Ooh, I like that.
It's all about localization, right? So by systematically testing all the different modalities in different areas, you're basically mapping out this sensory landscape and looking for clues to tell you where the problem's hiding.
I like that.
Yeah.
And the real challenge here, it's so subjective. It relies completely on what the patient is telling you.
Oh, it can definitely be tricky.
Right.
You've got patients who might be a little hesitant to say they can't feel something,
Oh, yeah.
or you have those who maybe exaggerate their symptoms a little bit.
Right.
So that's why clear communication is so important. And just as important, careful observation. You really have to, explain what you're doing, why you're doing it, watch their facial expressions, their body language.
Oh, absolutely.
Sometimes those nonverbal cues can tell you just as much as their words.
They really can. It's almost like you're a detective.
Absolutely.
Trying to read between the lines.
Trying to get the full story.
Okay, so we've got our basic sensory modalities, but then there's these higher cortical sensations. Do you find yourself actually testing these in general practice?
Honestly, they're not part of my routine exam.
Okay.
But there are situations where they can be really valuable. Let's say you have a patient who's got some, subtle cognitive changes.
Okay.
Or they're having difficulty with their coordination. Testing things like two-point discrimination, graphesthesia, or even stereognosis can help you figure out if there's a cortical component to what's going on.
So these tests become more useful when you suspect the parietal lobe might be involved, or other higher brain centers.
Exactly. It's not so much about diagnosing a specific nerve problem,
Right.
but more about assessing the bigger picture, how the brain is processing sensory information.
So it can help you distinguish between, say, a peripheral neuropathy and something like a stroke.
Exactly, yeah. It's like adding another layer of detail to your neurological assessment, helping you pick up on those subtle central nervous system issues that you might otherwise miss.
I like that. Okay, so now we've got all these tools in our sensory exam toolkit. How do we actually use this information to arrive at a diagnosis?
Well, that's where the pattern of sensory loss becomes your roadmap.
Okay, so tell me more about that.
You have to ask yourself, Is it confined to a specific area, like a dermatome? Is it symmetrical on both sides of the body? Does it follow that length-dependent pattern?
Interesting.
Those patterns, along with how quickly the symptoms came on, those can give you valuable clues about what's really causing the problem.
So it's all about connecting the dots, using those patterns, the patient's history, to guide your thinking.
Precisely. And for GPs, certain patterns just come up all the time. Let's start with mononeuropathies,
Oh, yeah.
those pesky nerve entrapment.
Those bread butter cases.
Right, we see them all the time. Carpal tunnel syndrome, ulnar nerve palsy at the elbow, peroneal nerve palsy at the fibular head.
We see those a lot, so we often jump to those diagnoses. But are there any red flags that would make you, reconsider, think twice?
Oh, absolutely. Like if the sensory loss doesn't perfectly match the expected nerve distribution, or if it comes along with some unusual symptoms like muscle wasting or significant weakness, then you really have to step back and think again.
So even those seemingly classic cases, you got to be on the lookout for atypical presentations.
You bet. They could be pointing to something more serious.
Interesting.
And don't forget about radiculopathies.
Oh, right.
Those often get misdiagnosed as just simple back pain or neck pain.
Mm.
But when a patient comes in and they have that radiating pain and sensory changes that follow a specific dermatome,
Yeah.
that's your clue to dig a little deeper.
It's like those dermatome maps from medical school.
Exactly.
Suddenly, they're not just diagrams in a textbook anymore.
They come to life.
They do. Like we see a patient with like classic sciatica symptoms.
Exactly. And recognizing those dermatomal patterns early on, it can make a world of difference. Helps you guide your management and make sure the patient gets the right treatment.
Makes sense. Okay, so we've talked about those localized nerve issues, but what about when you have a patient who comes in with sensory loss that's more, spread out, affecting multiple limbs? That's got to be trickier, right?
Oh, for sure. And in those cases, one of the most common patterns we see is that classic stocking glove distribution.
By the symmetrical sensory loss in the hands and feet, you almost automatically think diabetes, don't you?
It's definitely the usual suspect, especially if it's come on slowly over months or even years. But that stocking glove pattern, it can be a bit of a chameleon, can mimic other things you might not think of right away.
So what are some of those mimickers, the ones that can really trip you up?
Well, there's mononeuritis multiplex, for one. That's when you've got inflammation affecting several different individual nerves. And sometimes it can kind of look like that stocking glove pattern.
So instead of one thing affecting the longest nerves, it's like a bunch of separate nerve problems that just happen to be hitting both hands and feet.
Exactly. It can be tough to sort out just from the exam. You really need a good history, too. Like, is the sensory loss the same on both sides? Are there any cranial nerves involved? Any signs of something going on systemically? Those are the clues that might steer you away from a simple length-dependent neuropathy.
So even though the pattern might look similar on the surface, what's going on underneath is totally different. What else should we be thinking about?
Another one that can be tricky is Guillain-Barré syndrome.
Oh, right.
Now, we usually associate that with weakness that comes on quickly and gets worse fast.
Mm.
But early on, you can actually have prominent sensory symptoms in the hands and feet.
So you might see sensory loss before the weakness really kicks in.
Sometimes, yeah. So if someone comes in with those ascending symptoms and it all happened pretty fast, don't just dismiss sensory loss.
Got it. So how fast the symptoms develop is a key clue, right? Slow progression over years, think diabetes. Fast over days, maybe something inflammatory, autoimmune. Makes sense. Now, what about those cases where the sensory loss seems like it's coming from the spine?
Ah, that's where you have to know your spinal cord lesions. Take cervical spondylosis, for instance.
Okay.
Common in older folks.
Yeah.
Well, that can actually cause a stocking glove pattern of sensory loss.
Really?
How does that work?
Because of compression of the spinal cord up in the neck?
Wow, so the symptoms are in the extremities, but the problem's higher up. That's a good reminder to always think about the spine, especially with older patients. So how do you tell the difference between a spinal cord problem and a peripheral neuropathy?
Well, with a spinal cord lesion, you'd expect to see those upper motor neuron signs, like hyperreflexia, spasticity, on top of the sensory loss. You might even see some bowel or bladder dysfunction, and that's a big red flag.
Right, you wouldn't typically see those with a simple neuropathy. Okay, let's talk about some of the less common patterns of sensory loss. I remember reading about something called a CAPE distribution. What is that exactly? Oh, the CAPE distribution. It's pretty fascinating, though thankfully we don't see it that often. It's sensory loss across the upper back, shoulders, and arms. Almost like a cape draped over the body, hence the name.
I'm picturing it. Sounds pretty distinctive. What causes that?
Central cervical cord lesions.
Yeah.
So again, the issue is in the spine, but the sensory loss follows a very particular pattern. You see it once, you'll never forget it.
Okay, cape distribution, adding that to my mental library of those rare but memorable neurological signs. What about when the sensory loss just seems completely off, like it doesn't fit any of the typical patterns?
Yeah.
What do you think about that?
Then you have to consider sensory neuropathies.
Okay.
Those are rare, and they affect only the sensory nerves, not the motor nerves.
So these patients would have sensory loss but no weakness.
Right. And they often have really noticeable sensory ataxia,
Yeah.
meaning they have trouble with their coordination and balance because their proprioception is off. They might complain about being clumsy, having a hard time walking, feeling unsteady on their feet, that sort of thing. So how do you tell a sensory neuropathy apart from a length-dependent sensory neuropathy, since they can both affect multiple limbs?
There are a few key things. With sensory neuropathies, the distribution is often more patchy. It might not be symmetrical, one side worse than the other, and it could even start off looking like a dermatomal pattern, which can throw you off. But the real giveaway is the lack of motor involvement. Even with a mild length-dependent neuropathy, if you look closely, you can usually find some subtle signs that the motor nerves aren't working quite right, either on exam or on nerve conduction studies.
So if you see sensory ataxia, reflexes are absent, maybe some weird sensations, but no weakness, you got to think about sensory neuropathy.
It's a good place to start, yeah. And keep in mind, these conditions can be tied to other things like Sjogren's syndrome, some chemo drugs, even vitamin deficiencies, so a thorough workup is definitely needed. Okay, we've covered a lot of ground, from the everyday stuff to the really unusual presentations. Seems like the key is to really pay attention to the pattern of the sensory loss, how fast it came on, and any other neurological findings. Those are the pieces you need to put the puzzle together.
You've got it. And speaking of putting the puzzle together, that research you've got there actually includes some really helpful tables that can really streamline things. Like there's one that lists all the common mononeuropathies along with their typical causes and clinical features.
That's handy, like a quick cheat sheet for those nerve entrapment syndromes we see all the time. It's a good reminder of the anatomy, what might be causing it, and the key signs to look for.
Exactly. And then there's another one listing the investigations you might want to do for axonal and demyelinating neuropathies.
Oh, that's gold. Breaks it down based on what you suspect is going on. So if you're thinking axonal neuropathy, you've got your first-line tests, blood sugar, vitamin B12, protein electrophoresis. And then there are more specific tests depending on the patient's history and what you're seeing on exam.
It's like a roadmap to help you navigate those tricky cases and make sure you're not missing anything important.
These tables are so helpful for GPs. They give you that quick guidance you need when you're in the middle of a busy clinic day. Okay, so we've talked all about the peripheral nervous system, but what about when the sensory loss is coming from higher up, from the brain?
Now we're getting into the really interesting stuff. Central sensory processing. The brainstem, the thalamus, the cortex, they all play a role in how we experience sensation. And when there's a lesion in one of those areas, well, you can see some really unique and fascinating presentations.
Now you got me really curious. Let's dive into those higher pathways and see what they can tell us. Okay, so we've traveled all the way from those peripheral nerves up to the brain itself. Now, let's zoom in on those higher-level sensory pathways. You were talking about some really unique presentations. What were some of those?
Well, let's start with the brainstem. It's such a crucial relay center. Even a small lesion there can cause a whole cascade of problems, both sensory and motor. Take Wallenberg syndrome, for instance.
Okay.
It's caused by a stroke in a very specific part of the brainstem, the lateral medulla, and it leads to a very distinct pattern of sensory loss.
Yeah, I remember reading about this. Doesn't it cause sensory loss on, like, opposite sides of the face and body?
Exactly. You lose pain and temperature sensation on the same side of the face as the lesion, but on the opposite side of the body. It's a classic crossed finding, really points to a brainstem issue.
So if a patient comes in and they're complaining of numbness on one side of their face and the other side of their body, that's a red flag.
Absolutely. Big time. And along with that sensory loss, you'll often see other neurological signs that point to the brainstem. Things like ataxia, vertigo, nystagmus, hoarseness, maybe even difficulty swallowing.
Wow, so it's a whole bunch of symptoms together. Sounds like a real challenge to diagnose.
It can be, yeah. But recognizing that unique sensory pattern is the first step. And then imaging, especially an MRI of the brain, is key to confirm it.
Okay, so brainstem, check. What about the thalamus? We talked about it before as this major relay station for sensory information.
The thalamus, yeah, it's like grand central station for sensation. All the input from the body comes in there, and then it gets routed to the right spots in the cortex.
Okay.
So lesions there, they can cause a variety of sensory problems depending on exactly where they are and how big they are.
So what kind of sensory findings might you see with the thalamic lesion?
Often you'll see contralateral sensory loss, meaning loss of sensation on the opposite side of the body from the lesion.
Okay.
And it can affect all the modalities: touch, pain, temperature, vibration, proprioception to different degrees.
So it's not as clear-cut a pattern as you see with Wallenberg syndrome.
Right, exactly. And another thing to keep in mind with thalamic lesions is the possibility of thalamic pain syndrome.
Oh, yeah, that sounds awful. What's that like?
It's a chronic pain condition that can happen after a stroke that involves the thalamus.
And what does the pain feel like?
Patients often describe it as burning, aching, stabbing pain in the area where they have the sensory loss.
So even though the thalamus is involved in processing pain signals, damage there can actually lead to chronic pain.
It does seem like a paradox, but yeah. It's thought to be because of a disruption in the way the thalamus normally modulates those pain signals.
That's fascinating. So if you have a patient with contralateral sensory loss and they develop this chronic pain after a stroke, thalamic pain syndrome should be on your differential.
Absolutely. Recognizing it early is important because it can really affect a patient's quality of life.
Okay, so we've covered the brainstem and the thalamus. What about the cortex? That's where sensory information ultimately ends up, right?
Right. The cortex is where we become consciously aware of sensations. But isolated lesions just in the sensory cortex, those are pretty uncommon.
So what happens when you do have a cortical lesion affecting sensation?
You'll usually see a very localized sensory loss just in the area of the body that corresponds to the part of the cortex that's affected. Remember, the sensory cortex is organized like a map of the body.
Oh, right, the sensory homunculus. It's so cool how different areas of the cortex are dedicated to different body parts.
Exactly. So a lesion in the hand area of the sensory cortex might cause sensory loss just in the hand, but to cause a noticeable deficit, that lesion would have to be pretty big, and you'd likely see other neurological problems too.
So things like aphasia, neglect, maybe some cognitive impairment, along with the sensory loss.
Right, exactly. Those cortical signs are a big clue that you're dealing with a lesion in the cortex, not something in the peripheral nervous system or lower parts of the brain.
Okay, so cortical lesions, they present with a unique combination of localized sensory loss,
Yeah.
those cortical signs, and often other neurological symptoms as well. It's a whole different ballgame compared to what we see with peripheral nerve problems.
That's a great way to put it. And again, imaging is crucial to figure out where exactly the lesion is and how big it is.
Wow, this has been an amazing journey through the world of sensory loss. We've explored the pathways, the patterns, the diagnostic challenges. It's incredible how much we've covered.
I agree. It really shows you the complexity and the elegance of the nervous system.
And those tables you mentioned from the research, those are being so useful for GPs. Having that quick reference, right there at your fingertips, it can make all the difference.
Absolutely. Having those key investigations and clinical features right there in front of you can help you make the right diagnosis faster and make sure your patients are getting the best care.
It's been a really eye-opening conversation. I feel like I've gained a whole new understanding of the sensory system and how to approach those tricky cases.
And the key takeaway here is that sensory loss, it's not just about numbness, it's a window into the nervous system. By paying attention to those details, the pattern, how fast the symptoms came on, any other symptoms that are going on, you can unlock those diagnostic clues and provide the best care for your patients.
That's a great way to put it. And to our listeners, I really encourage you to keep exploring, keep asking those questions, keep learning. Neurology is full of these fascinating challenges, and the more we understand, the better we can help our patients.
Well said. And remember, even when the diagnosis isn't crystal clear, just acknowledging how complex the sensory system is and really listening to the patient's experience, that can go a long way in building that trust and providing support.
Couldn't agree more. So thank you for joining us on this deep dive into sensory loss. We'll be back soon with another fascinating topic. Until then, keep those brains engaged and those diagnostic skills sharp.